differential diagnoses. So first we want to go back to that medical notion. What are some of the health conditions that can mimic bipolar disorder? Temporal lobe epilepsy, that's when you'd want to get the sleep-deprived EEG. Hyperthyroidism, you can be really, really, really active, not need to sleep, not need to eat, if you're hyperthyroid. So you need to make sure that any kind of medical issues are being checked out. Closed or open head injury, and this can really come later because you can have a head injury and then significantly later start to show the prefrontal cortex result of that head injury. So sometimes, again, we need imaging to see what kind of damage has been done. If you're getting the early signs of MS and also of lupus, those can be, you can start to have behavioral and emotional dysregulation associated with both of those diagnoses. So you want to make sure that kids have had very nice, thorough physicals. If there's alcohol-related neurodevelopmental disorder, Wilson's disease. So again, you want to get your kind of full blood chemistries. How about medications that may increase cycling? Any biological intervention for depression can trigger mania in somebody who's susceptible. So our old-fashioned tricyclics, the SSRIs, the SNRIs, a phototherapy light box. So I have this very lovely young man. We started seeing him in the clinic in 4th or 5th grade when his therapist moved out of town, care transferred to me, and I was seeing him throughout late junior high, all of high school, and now he episodically comes back. He's finishing up college. He's like your dream patient. He sits down in the chair and says, well, the things I want to talk about today are, and he'll list 2 or 3 therapy agenda items that are absolutely on target, and we deal with them and we come up with a plan, and he goes out and he thanks me, and he's like, wow, if everybody was like this, I would feel like I'm a genius, you know? He makes me look so good. But very polite, very nice young man, lovely family. So one day he comes in and he's like right in my face. And I will call him Jason. I say, Jason, how are you doing? Great! Kind of like Tony the Tiger, great, you know? How's that light box working? Fabulous! I said, how long are you using it? An hour every day after school. I said, let's back that down to like 20 minutes. See what happens. He was using it in the morning and then using it after school. We backed the time down. He was right back to his nice, calm, even self. Okay, so light boxes, if you have, and he has a seasonal depression component to the bipolar. So rather than cranking up meds in the winter, we just crank up the light box. He cranked it up a little too high. His mood went a little too high. So anything can trigger mania. Any of your medicines for asthma, allergies, particularly some of the older medicines, any of the cough cold syrups, any of these can trigger manic-like reactions. The first thing you do, that's why you always want to, in that medical history, get a good sense of, did you start taking something new for any medical reason? And if that seems to be triggered with onset of symptoms, pull that out of the body and see if you go back to baseline. Some of the antibiotics. And then illicit drugs. If you're high on cocaine or if you're manic, I'm not sure I can tell the difference, and I want a drug screen. Okay. Let's talk a little bit about bipolar disorder and ADHD, because this is where the bulk of the questions tend to come in. And this goes back to my early point about why you want a video, not a snapshot. If I just look cross-sectionally in a what you see is what you get capacity, chances are good I cannot tell the mania from the ADHD, at least on many of the symptoms. What are the symptoms that have tremendous overlap and in a cross-sectional capacity are worthless for making the diagnosis? Irritability, almost ubiquitously present. Lots of talking. How many of you work, this is an ADHD place, so a lot of you work with lots of kids with ADHD. If I worked in an ADHD kind of primary clinic, when I would drive home at night, I wouldn't want the radio on. And why is that? I would want peace and quiet. Because kids talk, they talk, they talk, okay? And that's their baseline. And if that's your baseline, that's not mania, that's your baseline. And if you have ADHD, maybe the parents can get earplugs, you know? Distractibility, same thing. If you're always distractible, that doesn't count as mania. That's your baseline. Chances are good you have ADHD. If you have a lot of energy, in ADHD, that tends to, if you have hyperactive impulsive type, you definitely have a lot of energy, and that's your baseline. Those do not count. Where do you see some differences? Elated mood. Kids with ADHD can be very silly and giggly, but it kind of comes and goes, and you need to know their pattern and level. Okay. Grandiosity, you don't see grandiosity. In some kids with conduct disorder, you will see that kind of bragging. Okay. But you can usually stick a pin in it and the balloon goes, you know. You can kind of get that to go if you poke it just right. So you need to know how to do your poking when you've got somebody who does a lot of bragging with you. Decreased need for sleep, not the same as not sleeping, but decreased need for sleep, really not evident. Now there's some kids with ADHD who just really don't need to sleep much, and you feel really sorry for their parents. Their parents are the ones coming in with dark circles under their eyes because they're not sleeping, because their kid's not sleeping, and that's miserable. But if you've got a kid who's just kind of one of those really high energy, who really since a young age has gotten by on like 7 hours of sleep, you just feel sorry for the parents, but you don't diagnose anything in the kid. Hypersexuality oftentimes is what we will see in mania. What you need to be careful about is checking out sex abuse, or exposure to explicit sexual content at an age that's developmentally inappropriate. You need to make sure that you've checked that out. But otherwise, when you see hypersexual behavior, you need to think about a bipolar disorder. So I had the sweetest little 10-year-old girl who came from the nicest family, very religious, very kind of strong, strict morals. And when she became manic in the 5th grade, she started writing just filthy notes offering her services to the 5th grade boys. Multiple of these notes going out. Okay. You can imagine the family was horrified when they learned of this. Okay. This was not her typical behavior whatsoever. Or a teenager who might be sexually active but in an intimate relationship suddenly goes out and has 12 partners in a weekend. Okay. That's a problem. Psychosis, not part of ADHD, not infrequently part of bipolar disorder. I skipped something. Oh, suicidality, excuse me. Again, not part of ADHD, not infrequent in bipolar disorder. Thank you. Is it bipolar disorder or acute or post-traumatic stress disorder? You need to think carefully about this. Symptoms overlap. You can have just one, just the other, or both. Interestingly, Dr. Post, formerly of NIMH, in 2006 published a study and reported on the percent of adults with bipolar disorder who had experienced abuse or neglect in childhood. 52% reported 52% who had been abused reported childhood onset, and then the age of onset was related to how many had abuse when. So 34% had adolescent onset, 21% early adult onset, and 20% late adult onset. So you see the earlier, the abuse is associated with earlier onset. That's what I'm trying to say. So post-traumatic stress disorder, again, just to really quickly refresh your memory on this, you have to have had a traumatic event. And the child has to have a response, an emotional response of intense fear, helplessness, or horror that might look like disorganized or agitated behavior with new and persistent examples of re-experiencing, which can be dreams. So if you have disrupted sleep, is the kid tired the next day, and did they talk about a lot of really horrible nightmares, or did they just really not need to sleep? Are they kind of going through that reenactment? And do they have physiologic reactivity with exposure to any kinds of reminders? So is this somebody who looks on edge? Is this somebody who's just kind of agitated, or is this somebody who's getting triggered from the PTSD? A lot of avoiding thoughts, feelings, or conversations, avoiding activities, forgetting things, losing interest in activities that used to be pleasurable. So is this the anhedonia of depression, or is this kind of a response that's part of the package deal of the PTSD? Increased arousal, again, difficulty falling or staying asleep, irritability or anger outbursts, again, particularly when there's any kind of a trigger or reminder. So now when you see irritability, is this the irritability of mania? Do you see this flash that really fits better with an understanding of PTSD, or does it fit better with a manic kind of an experience? Okay, so difficulty concentrating, again, you might see that in either diagnosis. Acute stress disorder is pretty much the same, except it happens in that first month. So we'll kind of flip through that. Okay, so now let's go through the symptoms one by one and talk about why they might be part of mania, why they might really be part of something else. If you have a euphoric mood, normal kids, typically developing children, on special occasions will have transitory experiences of real joy, and that is wonderful, and we love it. It's your birthday, you're going to Disney World, something great. Is you just got a fabulous award at school. You wanted to be the star in the play and you got the role. And you're flying higher than a kite. Enjoy it. Wonderful. If you have drug-induced disinhibition, steroids, illicit drugs, you can be also flying higher than a kite, but it's going to take a while to come down and you need to get that drug screen. Or you need to know the medication history. So we've had kids coming out of medical treatment. Again, steroids are one of those common kinds of causes where you can see a lot of manic or hypomanic behavior. So you always want to carefully examine the contextual cues to understand the importance of what it is that you're seeing. Irritability is to pediatric mental health what fever is to pediatric physical health. No pediatrician says, oh my gosh, your child has the dreaded fever disease. You know, fever means something's wrong. When we see irritability, it means something's wrong. We have no idea if that's the only symptom you've got going, what the wrong thing is. It's in almost every diagnosis that we make in childhood. Medication side effects. As stimulants wear off, if anybody has ever coached or watched a soccer team that practices between 6 and 8 o'clock at night, you can be guaranteed that on a little boys' soccer team, at least one or more of the kids is on stimulant. It's like, just statistically speaking, it's practically a given. And if it's a long-acting medicine, it's probably wearing off, and you can get those whinies, okay? But if the only time you really see the whinies are in that 6 to 8 o'clock time at night when they're coming off their stimulant, that is absolutely not any kind of a mood symptom. That's stimulant wearing off, okay? SSRIs, SSRIs are supposed to treat irritability, but sometimes they're a side effect of the medicine. Sometimes you can become more irritable when you take the medicine. So that means that medicine isn't a good medicine for you. Okay, so we always want to think about how symptoms fall into place timeline-wise relative to any medications or illnesses the child has experienced. And then let's not forget that hot, hungry, and tired children get cranky. Grandiosity, true talent. So most of the work that I do is in mood disorders, but at various points in my career I've done lots of other things. And one day, in the middle of my lab that has all of these students who do very nice in-depth assessments of mood disorders, I was doing a learning disability evaluation. And I came out just to kind of see what my students would say. I posed, and I very artificially gave them part of the truth, not all of the truth. Said, I just had a kid who told me that once a week he flies to Chicago for violin lessons. What do you make of that? And they said, oh, well, what else does he talk about? And, you know, the bottom line was he's a really smart kid and he's really musically talented, and once a week he flies to Chicago and has a top-level musician give him lessons because he's just that good, and that's great. I had a girl who I followed who did have a mood disorder, who also was the star in the play, was the pitcher on the softball team. They had to create special awards in junior high school because she was the top award winner in every single subject. And if she got the top English award and the top math award and the top science award, nobody else would get an award, and that just didn't seem right. So they gave her the headmaster's award, and that way the second, first runner-up for every subject could get an award, and that made all those other kids happy. So she was just an incredibly talented person who also, when she got had family history of depression and family history of bipolar disorder, got a steroid injection for kind of a really bad sore throat, and then came to our special club called the inpatient unit because she was very psychotic. She talked about the special gift she had been given, and then when she was on the unit, she started talking in a perfect Australian accent, and talked about how the food was poisoned, but in the hospital. But more than that, in the pipes, her parents were spying on her by listening through the pipes because they could really hear everything she was seeing and they could see what she was doing, and it kind of just went on and on. So she had quite the response to this medication. But then when she came out of the hospital, I had the pure joy of following up with her through the rest of high school and episodically in college. And then once I've seen her since she's finished graduate school, very accomplished young woman. But she would come to me. She was another one of those people who's like, wow, if all my patients were like this, I would look like a genius. Okay? Because she would come in and she would say, I'm feeling, and she really understood the symptoms of depression and mania. And she had had a horrific psychotic mania, and she never wanted to have that again. And I was right there with her. I didn't want her to have it again either. So she would, spring of her junior or senior year in high school, she came in to see me. She said, I'm feeling a little stressed, and I don't know if I'm getting depressed or not. And I said, well, tell me what's going on. Well, she was the star pitcher for her softball team that was going to states. She had the lead role in the musical. She had just taken a bunch of those exams that you take, kind of the National Latin exam or French exam or whatever. She's doing all of that. She was finishing up her college applications. And she was like a straight A student. And I said, I'm getting kind of stressed listening to the list of things that you're doing. So I don't think it's you. I don't think you're getting depressed. We just would want to think a little bit about balance and how much is the right amount to do. And she wasn't getting into all of those things because she was sort of manic and grandiose and thinking she could do so much, but she was so good. The softball coach did not want to not have her. The person directing the musical really wanted to have her. Okay, so you kind of get the point. So you're going to work with some kids who just, boy, they've got it all. And you want to help them from a lifestyle perspective figure out, even when other people are demanding that from them, how do you set a lid on it so that you don't. When she went away to college, loved this girl, she said, I want to go to a really quiet dorm because I know I need 8 hours of sleep a night. Now, how many people going into college, and here's the strength, when you are working with somebody with bipolar disorder, if they have really taken to therapy and they have really learned how to manage their lifestyle, to manage their symptoms, they have more personal sophistication than the average kid their age, because they have really had to examine themselves and really had to look at how do I manage my health in a way that most kids don't even bother to think about. Okay, so sometimes you see these incredibly functioning people who have had to deal with very serious symptoms. Okay, so true talent, we've talked about that. When peers are unavailable, fantasy play might persist far beyond the time that we're supposed to have imaginary playmates or do this kind of imaginative play. So we had a 10-year-old boy in our study who pretended that he was a tax accountant. Not your typical play, I realize. Single mom, didn't live in the choicest part of town. There were some drug deals going on around. Definitely could not go outside and play after school, even in the backyard. Lived in a townhouse, was not particularly safe to be out. He had to come home, latchkey kid, lock himself in the house and stay there. So what's he going to do? He played tax accountant. Well, so he was on mom's keyboard, on her little adding machine. He never went to the mailbox to see if he was getting a return, okay? He knew he wasn't a tax accountant, so big deal, that's fine. My staff were a little bit, this is kind of weird. So, well, given his choices, I think he's awfully adaptive, good for him. By now he's probably finished an accounting degree and he's probably making more money than all the rest of us. So good for him. So normal behavior, what's the child's age? What's the developmental context? What's the persistence of the behavior? What's the effect on behavior? If I'm 7 and I tie a little blanket around my neck and I yell, I'm Superman, and I jump from the second step to the bottom and I pretend like I'm flying, don't I have a great imagination? Good for me, okay? But if I'm a 7-year-old boy and I tie that little cape around me and I jump out of my second-story window because I really think I can fly, that's not so good. Okay. Decreased need for sleep, it is not the same as decreased sleep. Lots of people don't sleep enough, but they're tired the next day, and that's the big difference. So if I'm depressed or anxious, and I've staved off those worries all day long, and then I pull up the sheets at night and mom turns the light out and it's dark and I start all my worrying, anxious ruminations, and I can't sleep for 2.5 hours. But the next day I'm miserable, I'm tired, I'm cranky. Okay, that's not mania. If I have poor sleep hygiene, so with teenagers in particular, you really need to get at what their social life is like. So if you're the kind of kid who's involved in several co-curriculars and you got this part-time job and you really pretty much do care about your GPA, so you work pretty hard at your school stuff, and then of course you have to be texting and on the computer and watching stuff on Hulu, and you've got a lot going on. So it's hard to get enough sleep at night. So then you don't really sleep enough, and then you take naps at goofy times, and well, that just sounds like a teenager who needs to cool it down a little bit, okay? And you can maybe help them do that, but that's not mania. Even if you might only be sleeping 5 hours a night, but then you're napping here and there, and it's just poor sleep hygiene. And good luck getting that teenager to do something about it, okay? Having your own children is a very humbling experience, and I can tell you that affecting teenager sleep behavior is not easy, okay? Excessive environmental stimuli. You move to a new neighborhood and it's loud late at night. So maybe you have trouble falling asleep. Well, that's because the horns were honking outside, not because you didn't want to be sleeping. If you take excitatory medications, or if you have a paradoxical reaction, you take Benadryl, because you couldn't fall asleep, but you're the kind of kid who on Benadryl, you go pshum, as opposed to pshum, okay? So don't take Benadryl, that's your message. But all of those result in fatigue the next day. What we see in our manic children is they normally, let's say normally they need 9 hours of sleep. Suddenly, 6 hours, 7 hours, they're great. So we've had kids who get up in the middle of the night and raid the refrigerator. A kid who ate a 2-pound block of cheese at 2 in the morning. That just kind of like makes me hurt thinking about that. We've had kids who wake up all the siblings to have a slumber party in the family room at 5 in the morning. Kids who are up and fully dressed and wake up, you're lying in bed sleeping as a parent, and suddenly you have that sense that there's somebody there, and there's the kid all fully dressed for school. I'm ready for school, except it's like an hour and a half before they're supposed to even wake up. Okay. So lots of, and then the other thing that'll happen is any TV that's on in the middle of the night is probably not something you want your manic child watching. We also get we've had kids who start using their parents' random dial on the cell phone and have made many unusual phone calls in the middle of the night. The sex phone lines, had kids racking up big phone bills on their parents' credit cards in the middle of the night. QVC, lots of things you don't want your kid doing in the middle of the night if they're manic. Okay, not a good thing. Pressured speech, somebody who's excited, nervous, angry might speak really quickly, but it'll go down as soon as that kind of affective state is kind of removed. It's a temporary thing. As we talked about with ADHD, you kind of have these chronic motor mouths. That's different than the pressured speech that we see. It's an intense, in-your-face, loud, hard to interrupt, right there kind of a thing. Racing thoughts. If you're working with, particularly if it's a new evaluation, the child is young, maybe lower IQ, particularly verbal IQ, or might have an expressive language disorder. And I'm thinking, just going from this topic to this topic to this topic, I don't know if it's that they're having racing thoughts or if I just can't follow their thoughts. Or they'll make lots of self-referential kind of comments that I can't track the connection. Bring in an interpreter, usually means mom. And if mom comes into the room and I say, we're talking about this and then this and then this, and then she can say, oh, well, what he meant was, and like the mom can totally follow the series of conversation. That's not racing thoughts, that's just, I don't know this child very well yet, and their communication, maybe they're not the greatest in expressive language, maybe they got a low verbal IQ, I'm just not following them, but that doesn't mean that it doesn't make sense to them and to somebody else who knows them. So you always want to keep that in mind. Distractibility. ADHD, again, this is our biggest differential. You always need to establish a baseline. Can't say that enough. There needs to be a change from baseline. For children with ADHD, to count double count now is a symptom of mania, and not just when medications are wearing off. So if you've got a kid who on the stimulant, long-acting stimulant, pretty under control, but then as it's wearing off at night, suddenly, well, every evening they seem to get manic. Well, what do you mean by that? Well, they have more energy and they're running around and they're talking more. It's like, sounds like their ADHD medicine is wearing off, and now you're seeing their level of real ADHD. That is not mania. That absolutely is not. In depression, kids don't concentrate so well. Kids with depression will talk about, it's like I've got cotton between my ears. It's like there's a fog that came down into my brain. They'll use very descriptive terms to talk about how they can't think straight. That's depression, that's not mania. In anxiety, kids will be very preoccupied. So if I'm sitting in school thinking, is anybody going to play with me at recess? Is anybody going to play with me at recess? Is anybody going to play with me at recess? Is anybody going to play with me at recess? I'm not listening to the math lecture. Okay, so I did get nothing out of that math lesson today, and then I can't do my homework that night because the whole time I was preoccupied thinking recess was next, and I wanted to know, was anybody going to play with me? Okay, so I might be very preoccupied and not paying attention, not being very distractible. And then if you have a learning disability, good grief. Here I am, I'm this reasonably smart person, but I go to school and I'm terrible at it because I can't read, and it's really embarrassing. And so I do anything to distract myself because I can't stand the fact that I can't read. It's really painful, okay? So you have to look at all the other reasons that a child might be displaying the symptom. Increased goal-directed activity. Psychomotor agitation comes right behind irritability is worthless in terms of making a diagnosis. Lots of kids will have that. Gifted children might be highly productive, like the girl I was describing earlier, but her work was very focused and she accrued mountains of accomplishments, okay? So that's not increased goal-directed activity in a pathologic sense, that was just a very talented young lady. Depressed, anxious, traumatized kids might appear agitated or have those kind of nervous habits. These are, if you're chewing on the collars or the cuffs, or you're picking at the bottom of the soles of your tennis shoes to the point that I worry that by the end of the session, the sole of their shoe is going to fall off because they've picked all the little rubbery stuff off the bottom by the time they've finished a session with me. You feel that agitation and the tension, but that so easily could be something else. It so easily could be part of an anxiety, or a kid who has PTSD, for example. Excessive involvement in pleasurable or risky activities. Again, sexual abuse, you never ever want to miss that when it's present. Sexual acting out often has kind of an anxious, compulsive nature. Hypersexuality in kids who are manic often has more of an erotic, pleasure-seeking quality. It's excessive, it violates social norms. So we've had little boys on the unit proposition our nurses on the inpatient unit. When a kid sidles up right next to you and wants to touch your jewelry at the first time that they've met you, you kind of wonder about that, okay? Again, and I gave you the example of the 10-year-old girl who wrote the very just filthy pornographic notes to the little 5th grade boys, or the teenager who'll suddenly have multiple sexual partners. You get that kind of, it's really excessive kind of a quality to it, very inappropriate kind of quality. Psychosis, as I mentioned earlier, if you're falling asleep, you're just waking up, you think you're seeing or hearing things, yeah, so do most of us. That's a big nothing. Suicidality is not pathognomonic of a mood disorder, but it's very commonly associated and obviously critical to assess and critical to get right on top of. Okay, so those are the symptoms, and that's how you want to think about what's differential diagnosis versus what's a co-occurring disorder. If you have bipolar disorder, it can co-occur with almost anything. So any of the behavior disorders, ADHD, ODD, conduct, tic, Tourette, substance use or abuse. Any of the anxiety disorders, we see particular overlap with OCD, but really GAD, SAD, very common in our kids. Eating disorders, you can have any of the eating disorders along with bipolar disorder, any of the learning disabilities. Once you have any diagnosis, your base rate of having a second diagnosis has just gone up from the general community. And then developmental disorders, understanding that whole autism spectrum disorder, I think, is very important for clinicians, even if you don't ultimately work in an autism treatment center. And in many, many communities, people tend to work in autism treatment centers, or they work in child psychopathology centers. Like, this isn't somehow related to this. And I think we do our field a disservice when we learn just this or just this. I've had the pleasure this past year of adapting our MF-PEP groups for kids with high-functioning autism, so the Asperger's, PDD, NOS kind of kids. And it's fascinating to me how I know something about that population, but I have always worked in a place where those kids tend to get funneled someplace else. So I just episodically, by happen chance, have treated some kids for whom Asperger's or PDD NOS would be their primary diagnosis. But I don't have as an extensive a feel and understanding of that as somebody who works in those centers. On the other hand, in those centers, they tend to really focus on that, and so having a really good handle on the ADHD or the anxiety or the mood disorder, there's a lot of lack of understanding of these two worlds, and we really need to come together because there are lots of overlap. And some kids truly have both diagnoses, but it's easy if you're in one camp or the other not to quite recognize the other. So I would encourage people to really become very familiar with kind of all of the sort of disorders that children can experience. So, just a few comments on treating co-occurring disorders. Some will be successfully treated in part by treating the mood disorders, many of the anxiety, behavior, eating disorders, but most will require some other kind of specialized intervention, other medications or psychotherapy, school-based interventions, or learning to cope with symptoms of those disorders. Okay, so now we're going to talk about biological interventions. Medication issue number 1. Medications do not cure a mood disorder, but they definitely help manage the mood disorder. They can stop or lessen current mood severity. They can prevent or decrease impairment from future episodes. They don't solve every problem. For medications to do their best, it is essential that families are an active partner in the treatment. And I have the distinct pleasure and honor of working with psychopharmacologists from around the country who are experts in pediatric bipolar disorder. I believe it's a true statement to say that each and every one of them would say that their medications that they work very hard to study and understand the treatment response of, they would be the first ones to say that our medicine alone isn't enough. We need your psychosocial stuff. Okay? So I think there's pretty good agreement that meds alone do not do. I wouldn't want to do it without medication, but I wouldn't ever believe that medications alone are going to do the trick for our kids. So issue number 2, partial responses are common. You want families to understand, don't despair. You might need to change the dose, the time the medicine is taken, the type of medicine. If it's given twice a day, maybe 3 times a day. You know, there's a lot of fiddling that you can do with medication. And then a full response is not a reason to discontinue. It may be useful to prevent future episodes. And this is a tough sell. If you have adolescent onset, it's that whole my drug, your drug kind of discussion that you can get into. What I have found with our younger kids, when they know what they were like not on medicine and they find a medicine that really helps to stabilize them, they don't want to go off it. They understand how bad it can be and they don't want to experience that. But if you are going to try a taper, you want to plan very carefully with the prescriber when and how to stop the medicine, never abruptly, lots of side effects if you do that. But you want to try taper during a time that's safe, which usually means over the summer. Medication issue number 3, so if and when you stop, do it with input from the prescriber. We talked about those side effects. One fallacy that parents oftentimes are concerned about, and again, remember that family history that we just looked at. So if there's family history of substance abuse, many parents come in very skittish and very nervous about the potential addictive qualities of our mood stabilizers or atypicals. And that's just a good piece of education. You can give families, these are not addicting medications that are prescribed. You want families to always get fact sheets about the medications, store them in a binder with all of the information about the disorder so that in one handy-dandy place you can pull out everything you need to know. Families need to understand the common and serious side effects. They need to understand that a lot of side effects are transient, and if you start really paying attention, you're going to notice lots of things. Medical students who start learning about the body suddenly have lots of symptoms. Pregnant women who are suddenly attending to their body might start noticing lots of things that were always there, but suddenly you notice it because you're really hyper-focusing on the changes in your body. When we're starting a new medicine, if we've been told these 10 side effects might occur, if you look at the rate in any drug study of the rate of side effects reported for placebo, it's kind of high too. Now, our medications for some will have higher side effect profiles, and that's what we need to understand. But the minute we pay attention to our body, we might notice more things. And then also the body will adjust to the medication as you're taking it. Families absolutely need to know what to do if there's a serious side effect. They need to know how to monitor the medicine. Do you need to get blood draws? Do you need to follow up how your kidney or your liver is doing? And it's always important for both the primary care physician and the psychiatrist or who's ever prescribing the psychotropics knows about all the medications, including over-the-counters, including herbal medications, any kind of nutritional supplements, etc. You want one person to know everything. So I had a great family. Mom was actually in the healthcare profession, highly educated family, nice kid, compliant with his meds. Had a very good primary care physician, but was on a combination of mood stabilizers, got put on Biaxin, had to go to the hospital and get a stomach pump because he was comatose when they came in the morning to wake him up for school. So you always need to know all the medicines, and all the prescribers need to know. Many of our pharmacies now have that red alert system, but it's not foolproof. So if you've been prescribed 2 medicines that are contraindicated, there should be a little red alert so that the pharmacy doesn't allow you to get those, but it's not 100% foolproof. Timetable, many medicines, particularly in the atypicals and the mood stabilizers, take a long time. It's not like a stimulant that if you take it in the morning, if it's going to work that day, and then it's going to be gone. Our mood stabilizers, our atypicals, will take oftentimes a couple of weeks to really maximize benefit. So we want families to understand that they need to be patient, not give up too soon. There's no benefit to every 3 days trying a new medicine. You have no idea if the first one was going to work. And as we mentioned this morning, physical symptoms may improve before the mood and thinking do. There's some very low-tech issues that are very critical in taking medicine. If you're taking medicine for bipolar disorder, you're probably going to be taking it for a long time. Now, I don't know about all of you, but I can't get through 5 days of antibiotic remembering if I've taken it or not, unless I have some way of seeing a pill count. Okay? So having a plan and a backup plan is really important. I cannot imagine taking medicine every day without a pill holder. Okay, so you've got to have some kind of a pill box that says, this is Monday. Did I take Monday, or was I just remembering taking Sunday's medicine? Okay, having a morning ritual around breakfast time or however the medicine is prescribed, having kind of rituals around it to make it easier to remember. And families need to understand what to do about missed doses. At what point do you still take it if you remember? At what point is it dangerous because you're too close to doubling up? Those kinds of rules really need to be understood by the family. And families need to plan ahead to get refills on time. Again, this is all very low tech, but this is kind of like the make it or break it stuff that makes it work for families or not work for families. And we can help coach that through as part of our behavioral management. Some medications need blood levels. The same dose can produce very different levels in different people depending upon how it's metabolized. And for example, with lithium, lovely medicine, but you really have to stay within the therapeutic window. Too little, it won't help. Too much, you can get very, very toxic on it. How do you do this? You get levels 12 hours after the last dose, before the next dose, or you will cause cardiac arrest in your prescriber who gets a level back that's astronomically high because you just took your lithium and now you got your level. And that's not a good way to do it. So you postpone the morning dose till after the blood draw. Okay, so those are just some kind of technicalities that I think even when you are not in the prescribing world, it's really important to be knowledgeable about that because we're coaching our families through those very fundamentals, and it's important to know that. So medication update, this is now from 2008, and studies keep coming in. There's been a lot of progress made. 3 years ago, there were 11 RCTs of substantial size. There is unequivocal evidence for atypicals. You pay a price when you take an atypical. There are a lot of side effects also, but in terms of mood stabilization, they can be very beneficial. Topamax has had 4 negative RCTs in adult. There was some positive outcome in an adolescent trial that got stopped when the adult trials were negative. But it sometimes gets used. And here you see a nice review done by Dr. Koech and Dr. Post, looking at the drug, the evidence for it, problems associated with the medication. Tolerability is kind of the rating of the side effects and how bothersome they are. Are they nuisance or are they really problematic? And then overall utility is kind of combining that evidence along with the tolerability. And you see the grades are mostly around a B. Lamictal is very nice for some kids, does not work. We've had some negative trials with that. Does get used fairly often. And you see the grades are kind of on average Bs, so some As. So we've got some, Abilify gets used quite a bit, Seroquel gets used quite a bit. In terms of medication algorithm, what might you expect that your kids will be prescribed if they have bipolar disorder? Step number 1 would be an atypical antipsychotic or a mood stabilizer. If there's poor tolerability, the recommendation is to switch within that drug class, so from one atypical to another. If that's not enough, then you add the other class. So if you started with an atypical, then you would augment with a mood stabilizer. Next step would be adding lithium. Next step beyond that, another combination within the same class of medicine. Then add another atypical, switch the atypical, and then switch the mood stabilizer to carbamazepine. So those are the 7 kind of reasonably devised clinical recommendations for medication. You don't often get all the way to number 7. What do we know about treating comorbid disorders? This again comes out of our roundtable that was published in 2005. These guidelines are really primarily anecdotal. So it's taking a bunch of clinicians who are researchers, bringing them in a room and having them kind of vote on how they manage this because we don't have any better data. Most studies are focusing on one primary diagnosis. So keeping that in mind, this is as good as we've got. In almost every case, the notion is stabilize the mood first. We like to think about, and we talk about in our parents' book, that you want to stabilize the mood and then you want to kind of re-sweep up any remaining symptoms. You kind of sweep all the symptoms into little piles. And then when you kind of have taken care of the mood, see what piles are left. Sometimes the other disorders start to get better simply by treating the mood, or it was more like an epiphenomenon of the mood disorder and not even maybe its own real diagnosis. But after you've treated the mood, you kind of take a second look at what's left and then you start making treatment plans for the what's left. Treat sequentially, and whenever possible, use psychosocial treatments, and that's when the treatments have some evidence behind them to suggest efficacy, when the families are willing to do the work. Psychotherapy is work, we all know that, and when there are trained therapists available. What do we know about treating comorbid ADHD? This is highly comorbid with bipolar disorder. Most of our younger kids, 12 and unders, also have ADHD, and a sizable minority of adolescent onset bipolar disorder also has ADHD. Medications are the first-line treatment, but you go low and slow, and you always augment with psychosocial interventions. So parent training, school consultation, all of that good stuff that we do with ADHD. So you absolutely want to have that part in place too. Treating comorbid disruptive behavior disorders. Some of the medications, the atypicals, for example, if you have a highly aggressive child, oftentimes brings down the aggression a bit. But then we know the evidence-based for disruptive behavior disorders, and that is parent management training, and you absolutely want to do that. At times, you also need to augment with some environmental changes, such as residential placement, foster care. Those are things that are really further on down the road, but sometimes we get to that level. Comorbid anxiety, whenever possible, use psychosocial treatments first in dealing with those. We have the most evidence for CBT. If CBT isn't available, the family really is not able, willing to do the work, then you start thinking about medications. SSRIs, you want to be very cautious because, again, remember SSRIs can trigger mania. So if you've got somebody who's comorbid, you want to be very careful about that. Buspirone is not effective, and the benzodiazepines have limited data. They have great abuse potential. There are cognitive side effects. Some people will use it in a very short-term capacity while you're waiting for the other medications or you're waiting for the CBT to really kick it into gear and take care of the problem. Treating comorbid substance abuse, this is one exception to the treat sequentially rule. This is where you want to get in and do both all at the same time. So if you've got somebody who has been abusing alcohol or drugs, you've got to clean their system out right away, or you don't really know what you have left in the mood camp. There's one study of lithium that's now a little over 10 years old, indicating some efficacy. But then we know that really for substance abuse, where do we go to for intervention? Family-based therapy, and we've got multiple citations there. Pervasive developmental disorders, the whole autism spectrum. You want all the kind of treatments, the ABA, IBI kinds of treatments that are available. Same thing for mental deficiency. Seizures or migraines, you want to then think about, rather than starting with an atypical, you're more likely to start with a dual purpose medication. So the mood stabilizers that are also have anti-epileptic properties can sometimes take care of both problems for the price of one. Premenstrual dysphoric disorder, oftentimes SSRIs will be added on after the mania has been stabilized. What do we know about maintenance treatment? Not much. Most of our medication trials are very brief. If we get a 6-month follow-up, we're doing well. And we know that most of our kids need medicine a lot longer than that. In general, we know that agents that get you well keep you well. We know that discontinuation is likely to lead to relapse. This is now it's a very classic study done over 20 years ago by Michael Strober at UCLA, showing that there was about a little over a third of the kids relapsed if they stayed on their medicine. Almost all of them, over 90%, relapsed within 18 months if they went off their medication. You want to try to work toward monotherapy. So let's say you've been hospitalized, you come out on 3 medicines. You want to work toward bringing that down to 2 medicines, maybe down to 1 medicine and starting to lower the dose. But you want to try getting off the medicine during the most stable time, which for most kids, low stress, stability would mean summer. But if you are in, for example, a divorced household where in the summer you go down to live with dad in here it'd be going up to North Carolina, to live with dad over the summer, whereas in the school year you're with mom or whatever, you want to make sure that all the parents are on board. You want to make sure that the psychosocial environmental world hasn't changed dramatically, so that you're doing it during a very stable time. You want to do this slowly. And our best recommendation, and this really is from clinical research, anecdotal evidence, not sure I can even say anecdotal evidence in one phrase, but you want to stay on the medication dose for at least 18 months post-stabilization. One thing that we do sometimes see is what I call the poop out factor, where an atypical works really well, and about a year later it just stops working, and we don't know why. And then you switch to a different atypical and it works pretty well, and that might work for another maybe about a year, and then it just stops working. And then you have to switch to a different, it's not even a matter of switching dose, it just stops. And I don't know anybody who's got a great explanation for that, but we see it. There are other kids who can get on a medicine and stay on it for years and years and years, and it continues to be useful for them. We don't know why that is. By the time we all retire, we should know a lot more about that. You want to always use a cost-benefit analysis, and you want the parent and the child to be very, very active contributors. Ultimately, it's the kid's life. So how do they weigh the cost-benefit analysis? Managing side effects, again, as the behavioral psychosocial treatment provider, you can really help with this. There are some predictable side effects, and there's some very easy ways to help alleviate the discomfort from those side effects. So you as a psychotherapist want to be familiar with this, even though it's not the treatment that you are providing. It's part of the comprehensive care. And here you see a very straightforward list of things to do. Dry mouth is very common. For example, if you're taking lithium, you get that, it's an uncomfortable kind of a feeling. We had a boy who was just entering junior high who had been beautifully stabilized on lithium. He was in our MFPEP trial, and he actually functioned remarkably well. His mom had to go to work, single parent, had to go to work before he caught the bus to go to school. This kid in junior high was reliably getting to school on time, letting himself out of the house, locking the door, being very responsible. He stopped taking his lithium and he started getting very wobbly. Well, why is it that he stopped taking his lithium? Because he couldn't have a water bottle in class because the school policy was you don't have water bottles in class. And if he went to the drinking fountain really often, then he had to go to the bathroom and he couldn't get bathroom passes when he needed to. And I don't know about you, but I don't know any 7th grade boys who want to pee their pants at school. Okay. So he stopped taking this medicine that worked beautifully for him out of a really dumb reason. So a little bit of work with the school, got him to be able to carry a water bottle around, got him unlimited bathroom passes, and voila, back on the medicine, stable, did beautifully. Okay, so those are very low-tech solutions to some potentially very disruptive problems. And I'll just kind of quickly go through the list here. You can look at these. Tremor, we'll see kids whose handwriting gets a little bit bad. Try to get the school to not really care about handwriting. Most schools really don't anymore, and most kids are keyboarding anyway. Avoid caffeine. And let me just tell a little story around this. You might think that families, particularly if they're fairly well educated, would have a good sense of sources of caffeine. So I was treating a boy who I'd first seen in about the 4th grade, and he's the neatest kid. I love this kid. He comes in to see me for the first evaluation, did not have any mood at all at that point in time. And I'm talking to him, and then he says, "Do you want to see something?" I said, "Sure." He unzips his coat, and I'm thinking, what's he going to show me? And he opens up his coat, and I'm thinking, where is this going? It's like the stolen watch out of the pocket. You know, and he pulled out, this was back when we had discs, so one of those little discs. He was a writer, and he had stories on this disc, and all of his stories were on this disc. Neat, creative kid. Took me a long time to figure out he actually had ADHD. And why did it take me so long? He was inattentive. He was very bright in a not very challenging classroom setting, in a public school that was not challenging. And it wasn't until he took chemistry as a senior that the task demands of the class really made it apparent to me that the little bumps in the road that we kept getting all the way along 4th grade on was little tiny. But at school, he was like this very well-behaved, very polite child in a school that wasn't known for polite children. So he kind of stood out as like the good kid. So, you know, you don't think of ADHD. The teachers weren't reporting it. The parents weren't reporting it because he kind of was functional in the home. So anyway, so we finally get to ADHD inattentive type. He also had a lot of sleep problems. And I said, "Do you drink any caffeine in the evenings?" "Oh, no." So, "Well, what do you drink with dinner?" "Mountain Dew." "Just for kicks, what do you drink after dinner? If you drink anything?" "Oh, Mountain Dew." "Just for kicks, tell me about like how many Mountain Dews a day do you drink?" "Oh, about a 6-pack." This was a well-educated family. This was a very bright child. They had no idea. How they didn't, I don't know, but it humbled me to remember, I can't just say, "Do you have caffeine?" but I go through sources of caffeine, okay? If you drink 6 Mountain Dews from 5 p.m. onward, you will probably have trouble falling asleep that night, okay? When his sleep cleaned up, he was not nearly as grumpy and irritable in the morning, and he actually didn't have depression. He only had ADHD inattentive type. How about that? Excessive weight gain, really common with our atypicals and mood stabilizers. Kids can really chunk out. It's not good for their body. It's not good for their mind. It's not good for their emotional self. We've had kids double in weight. It's amazing. So we really need to focus on balanced diet, regular exercise. We don't want kids doing drastic diets, diet pills, that sort of thing. You're going to hear more about managing sleep, eating, and exercise this afternoon. Skin sensitivity, impaired sleep, and again, we're going to talk more about sleep hygiene this afternoon in our treatment, and that's really important. And with kids, you'll have a bit more success. It's a very humbling experience to work on sleep hygiene with teenagers.